Whenever you're ready, Rodrigo.
All right. Welcome, everyone. Good morning. This is Rodrigo Monterrey. I work in the Office of Health Equity at the Department of Public Health. And I want to welcome you all to the first session in our series of the Oral Health Equity Summit. Give me 1 second here. I see that we have lots of people joining. So I will
maybe give it
get started in just in a couple of minutes.
Yeah.
Of Health Equity at the Department of Public Health. Welcome to the first session in the series of the Oral Health Equity Summit. I will give me 1 second just to get going here. Thank you for joining us for our Oral Health Equity Virtual Summit. This was originally planned to be a one-day in-person event, but due to the COVID-19, it is being held as a series of weekly virtual presentations. As I said, my name is Rodrigo Monterrey, and I'm the Deputy Director for the Office of Health Equity at the Massachusetts Department of Public Health. And today I will be the moderator for our presentations. To start with, I just want to go over a few housekeeping items. You may have noticed, but everyone has been muted upon entry to minimize background noise. So if you have a thought to share or a question to ask, please put it in the chat box, which is located at the bottom of the window, and we will moderate questions in the last 15 minutes or so of the session so that our presenters will be giving their presentations, and we will be collecting any questions that come up during the presentations and then save time at the end of the session to address the questions. The webinar is equipped with a CART reporter who will be doing closed captioning. To turn on the closed captioning, just hover over the CC icon at the bottom of your screen and click Show Subtitles. These presentations are being recorded and will be shared and posted on DPH's Oral Health Equity webpage, which is on mass.gov. If you need CEs or CEUs, continuing education units or credits, you will need to be present for the entire 90 minutes, and then you will be asked to complete an evaluation, and then we will email out the CEs once the presentation has ended. Lastly, since we have so many participants, it makes sense to mute everyone, like I said, to avoid any distracting noise, so that only our presenters will be heard. But please feel free to type your questions or comments into the chat. These messages in the chat are visible to everyone unless you specify that they be addressed to a particular person. So others will be able to reply, and we want to allow this so that it'll encourage some interaction or exchange between our participants. However, it also makes it a little harder to keep track of all the questions that are coming up. So if it's a question specifically for the presenters, make sure that you address it specifically to them. And we also have a Q&A button or option. So you can use that as well. And then the moderator, being myself, will be able to control this and check off those questions as they are addressed. And the ones that haven't been addressed are the ones that we will address at the end of the presentations. Now, before we jump into those presentations, we have a poll question for everyone. So let me get that poll question going. Hopefully everyone can see the poll question that is on the screen. Please take a minute to answer the question. This will give us a sense of who we have in the audience. I see that about 2/3 of our participants have responded. I have about 3/4 of our participants have responded. I'll leave it up for 5 more seconds before we close the poll. Thank you so much for responding to the poll. We had just a little over 80% of participants respond. We see that most of you in the audience, almost half, are dental professionals, but we also have some medical professionals, health educators, community health workers, folks in early intervention programs. We have school nurses, and then we have other. I'm sharing the results so everyone can see. The other thing we want to do is use the chat so that folks can check in on the chat. And that way other people can see who else is on the webinar. Okay, so I will be introducing the presenters shortly, but before I do that, I want to give a quick overview of the Oral Health Equity Project, or we call it OHEP, Oral Health Equity Project. There will be a more in-depth presentation about the OHEP, which will be during our last session, which is on June 12th. So I'm just going to give a very quick snapshot, but I think it'll be helpful to provide some background on how we got here today. The Oral Health Equity Project, or OHEP, is a collaboration between the Massachusetts Department of Public Health's Office of Health Equity and the Office of Oral Health. The Federal Office of Minority Health funded this collaboration through a 5-year state partnership initiative grant. And that grant is also funding this series of webinars. So thank you to our federal funders. The grant required that states choose a Healthy People 2020 leading health indicator to address. And Massachusetts chose the leading health indicator for oral health. The indicator for oral health for Healthy People 2020 is increasing the number of persons who visit the dentist in the past year. The reason we chose this health indicator is that oral health is one of the few health indicators where Massachusetts was not showing improvements over time. In fact, the data showed that access to dental services was declining year to year. The grant also required that states identify a priority population in 2 geographic areas. So Massachusetts focused on children up to age 14 in the communities of Worcester and Holyoke. These are 2 racially and ethnically diverse cities with disparities in oral health access and outcomes in Massachusetts. We chose to focus on children because our data show that approximately half of the children up to age 14 who are on Mass Health, which is our version of Medicaid, had never been to the dentist in their lives, despite having coverage. So we felt that this was obviously an area where we could make some improvement. Now, the OHEP has 2 overall goals. The first is community impact. We want to increase the number of children up to age 14 from low income and racial and ethnic minority communities, particularly in these 2 cities, Worcester and Holyoke, who visit the dentist. in the past year. And then we were aiming for statewide impact, meaning we wanted to disseminate our lessons learned from the project, both from the methods and the results, and then use what we learned to develop plans for statewide adoption, for scaling some of these as best practices to reduce oral health disparities. The way we did that is during our first year, we carried out a variety of community engagement initiatives to better understand the needs and the opportunities for improvement in these two geographic areas. Having done that, that led us to seek partnerships across a variety of service systems that touch children 0 to 14, such as early intervention programs, public schools, community health centers, and WIC sites. Then starting in year 2, we implemented these interventions across those service systems and started collecting data. And now we're in year 5. And so we are focusing on the dissemination of findings and the sustainability of these efforts. We're doing both by scaling and replicating the models that we've implemented in the 2 pilot communities and by publishing and presenting findings and lessons learned at conferences. So this series of webinars is part of our dissemination effort for this grant. So thank you all for participating. Now, without further ado, I'd like to welcome Dr. Matthew Horn. He is the Dental Director for the Office of Oral Health at the Massachusetts Department of Public Health, and he's going to give us an introduction to oral health in Massachusetts. Matt, take it away.
Thank you. Just give me a second to get my slides up. One second. Great. And you should be able to see my slides now, correct?
Yes, we can.
Great. So thank you, Rodrigo. I am Dr. Horn, Matt Horn. I'm the Dental Director at the Office of Oral Health, and I'm actually very new in my role. I got to start in December 2019, and in a profession that's had little change in hundreds of years, seemingly. There was a pandemic within the first few months of my working at the department. So it has been an interesting ride already, but I'm happy to share the slides today with the group. My pronouns are he, him, and his. And I think that also when we're talking about health equity, it's important that I give a little bit of my background information in terms of the lenses and filters that I apply when looking out into the world. I grew up in Western Massachusetts. That's where I spent the first 18 years of my life, in a town called North Adams. And that's a very rural setting. There's little racial diversity there. And there's still a lot of poverty in that town. In the last 12 years, I've been living and working in Dorchester, which is Boston's largest neighborhood. Would be considered, I would say, very diverse area, a large mix of income, and it's a much larger population and much more urban area. So definitely there's 2 spectrums that I've gotten to experience, and I think that's definitely impacted my filter looking outwards. So I'll share that as a starting point. So the Office of Oral Health has been participating in many strategic planning activities over the past few years, prior to me coming on board and then really getting solidified as I started. And achieving health equity, I've highlighted many areas that phrase or versions that are important to it appear. It's not only in our office vision, the Office of Oral Health vision statement, but it's also in our mission and multiple goals, which is important to know. Like, this is the end game that we're really hoping for in the Office of Oral Health. The concept of overall health and oral health being linked, I know it's been around for more than a decade, and many of the people on the call have heard it in many ways. And I hope that by the end of the webinar, you have a new appreciation for why that's so important, and how it might impact health inequities. Great. So the Department of Public Health Office of Oral Health has many activities that it's currently engaged in. I just wanted to highlight some of them from a high level before we get into the Oral Health Equity Project. And thank you, Rodrigo, for giving a much better description of everything that entails. you can take a look at all those areas where we're actively working. And I'll let you know that the FMR program is a fluoride mouth rinse program. And also, I think it's important to note, because I know there might be people from other states on the webinar, that in Massachusetts, the Office of Oral Health Dental Director, myself, I works in collaboration with the state Medicaid dental director, who's a different person, Dr. Catherine Hayes, who's wonderful to work with, and she's also very new in her role. So we're a new team coming together to take this effort on. Okay, so when you search health equity, one of the starting points of understanding becomes knowing the difference between quality.
Excuse me, I'm sorry, this is the cart provider.
Yes.
I'm having trouble hearing you. You seem to be cutting in and out. I don't know if, oh, and I see in the chat box other people having the same issue. Okay, it's not just me.
Okay, let me try to move my monitor a little bit, or my...
I'm sorry for interrupting you.
No problem at all. Obviously, people can't hear me. Is that any better?
Hi, Matt. This is Rodrigo. Yes, we can hear you perfectly, but all of a sudden, it seems to happen every time you look up or away. I don't know if you have a microphone that's in one area and then...
It's in my laptop, so I'll try to just keep my head more like this. I'm sorry. I know that's frustrating when you're on a webinar. If it gets blurry again, please just stop right away. You won't impact my train of thought. Well, you probably will, but don't worry about it, okay? So when you are searching about health equity, this artist, Angus McGuire, this photo comes up often, this image. And I think it's a nice way of starting to understand the difference between equality and equity. I know Minoshki is going to dig into this a lot more, but I like it because if you're a visual learner, you can appreciate more of the difference between the two approaches. Okay, so a little bit of basics from this image that you can take away is that different people have different needs. And always starting with the same thing is much different than providing people with their specific needs. So I think that's, you know, in an equal world, people get the same resource pool, and then in an equity world, people get the resources specific to what they need. And those crates, I think it's better to look at them not only as resources, and when I'm saying resources, I'm meaning programs and policies. And the fence there that I'm pointing out, I like to think of the fence as the social determinants of health, because if the fence was gone, then you wouldn't need as many programs and policies, which is, it's a newer way of looking at the same image, but I think it's very powerful that it's possible to remove the fence. Other things to consider would be infrastructure in general. And that in this image, you can think of that as the grass underneath everything. And winning the game, as I mentioned, is health equity because everyone has the opportunity to be healthy. And for a little bit of an extra credit or a more out there take on everything, you can think of the weather in the image as measurement, because measurement and data in general is super important for driving change and being able to play the game, so to speak. I'm hoping my audio is better. So in framing the conversation about health equity, it's important to think about systems level of change and not individual level of change, even though the previous image I showed individual.
Matt, I'm sorry to interrupt you.
Yep.
Your audio was great for the previous slide, but now it started cutting in and out again.
I'm not sure what's changing. Is that any better? I just moved my computer again. I'm so sorry for the people on the webinar. I hope it's more clear at the moment.
Do you have headphones that you might be able to use?
I don't have any headphones, no. Do you want to go out of order and have me try to call in? Is it that bad, or?
Well, the closed captioning, as long as they can capture what you're saying, may be able to complement and for folks to follow along. If that becomes a problem, we'll let you know.
Okay, thank you. So switching to that systems level outlook is key to addressing health inequity issues, I think. And I'll outline some of those areas where things are easy to, well, not easy, but a way where we could approach and start looking at health equity issues more broadly in oral health. So first of all, our two big diseases, dental caries and periodontal disease, are 100% preventable, which is a great place to start. So we can reduce the cost burden to the system if we can address things as prevention or true prevention activities. And I like the visualization. A lot of these visuals come from a DentaQuest toolkit. It's from a group called, a website called frameworksinstitute.org. So if you like some of the visualizations that I'm describing of health equity, that's where they come from. Oh, great. Hopefully you guys can still see me and hear me. So one of the visualizations that's powerful is how they describe accessing good oral health as being like moving through a series of locked doors. And I liked that visualization. So one door might be having fluoridated water. Each door has a specific lock and each door has a unique key. So as the population is moving through those doors, another one is healthy food. Another one is dental insurance or access to care. You can think of it as multiple doors in a row. So some people are able to access all those blocks and others are not. And then I think the last thing that's important is that there's a huge team that plays a role in the oral health care system. Although we have some more traditional roles on the webinar as our dominant group of attendees, the dentists, dental assistants, hygienists, it's important to remember public health dental hygienists, primary care providers, nurses at schools, community health workers, pediatricians, and I would say administrators and even health insurance systems are critical as part of the team. So there are some areas where we have documented existing inequities in oral health in Massachusetts. Those areas include income, age, race, and geographic location as drivers to health inequities in oral health areas. And then I think it's good to note our FENS, our social determinants of health, which is what SDOH is short for. In the Commonwealth at the Department of Public Health, we use this tool, this little graphic to represent them. And it's adopted, this graphic is really an adopted and expanded form of the Healthy People 2020. So if you're familiar with that graphic. And in this image, you can see that economic stability has been pulled out more specifically as one of the key components, one of the key social determinants of health. Employment around poverty, housing in terms of instability and homelessness, and crime and violence and other experiences of trauma are also called out as special focus areas. And then it's good to see in the hub is chronic disease prevention, which you could see oral health fitting into nicely. And I think education in terms of health literacy in general and oral health literacy, and then the built environment includes things like access to healthy foods and access to healthcare. So around income-based inequities, let's look here. So one of the first, these findings that I'm going to summarize in the four main groupings that I mentioned earlier. I'm more using them to trigger questions for people to be asking in their head as they learn additional information from the other presenters. So despite only 25% of the state population being covered by a Mass Health, which is our Medicaid dental program, the program itself paid for that represented 48.8% of all preventable ED visits. So you should be thinking, or you can start to think, what barriers and which of those social determinants of health areas that I mentioned earlier must Medicaid members be navigating to result in the disproportionate representation of the ED use? And how can the system be changed to improve that? Those with household incomes less than 25,000 reported tooth loss at 45% compared to those making 50,000 or more, which only had reported 25%. So that means that half of the income amount led to a doubling approximately of reported tooth loss. So which social determinants of health are responsible? And there's also a huge cost difference between the location of care. So the ED visit itself is 4 to 7 times more expensive than an emergency dental visit handled in the dental office. So why? And how do we encourage the less costly path of care and place of care? I thought this was important. The most commonly cited reason for not visiting the dentist within the last 12 months was cost. This is most commonly reported problem was difficulty chewing, biting, experiencing pain, disproportionately higher amongst lower income adults. So a clue around the main barriers at the patient level are cost and fear, and we see that repeated in several surveys. So what's necessary to improve that? Policy, health education. It's good to start thinking that way on the systems level change. So the second area there was age-based inequalities, inequities rather, caught myself. So young adults 19 to 34 are more likely to use the ED for a preventable oral health issue. So is this a health education issue from their youth? Is it an access issue? Is it something that can be fixed with a policy? Or is it something related to their coverage of insurance? And then repeat ED use is 3 times more. So that means if you've used the ED 3 times or more in the measure period, that was 30% of the users. So that means there's a subpopulation that needs repeat ED use. Does that point to a continuous problem and continuous barrier with the same social determinants of health? And more research is needed in that area for sure. And then I think it's good to know that residents in Massachusetts already do value oral health in terms of the concept that they perceive it as, which in this survey was straight and bright teeth, which for the dental people on the call, we know is a lot more than just straight and bright teeth. But I think it's good to know that people already have a concept of what it means for them for value and wellness in oral health. So race was the third area that I mentioned of existing inequities in oral health in our state. And we can see that through non-Hispanic Blacks utilizing the ED at a rate of nearly twice of any other group. So, and also the highest concentration of uninsured. These are certain sub-neighborhoods of Boston, and by race, reporting that they're having tooth loss due to gum disease or decay. And you can see how that percentage of reported loss differs from the white subgroup. So what social determinants of health impact these groups specifically? And as I started with my lens and filters, what lens and filters and social determinants of health would be applied to this group? And again, I think there's going to be a lot of more good information in this area coming from Minuski's presentation. And the last area I mentioned was inequities based on geographic location. So in our state, there's certain counties that have a higher utilization of the ED, and I'll have some visuals to kind of explain that more in a moment. And then the percentage of dentists that are billing at least 10,000 in total claims is there's twice as many concentrated in urban areas than in rural areas, really. And there's a corresponding relationship of emergency department visits by area as well. So in this map, you can see the concentration of practicing dentists per 1,500 residents. And the basics are urban areas, greater Boston, which is shown on the right there, as well as more wealthy areas or high income areas have more dentists. It seems to be more dentists are concentrated along the coastal regions, and also where our state's 3 dental schools are, which is in the greater Boston area, Tufts, Harvard, and BU. And you can see the left-hand side of the state, Western Massachusetts, is the lowest concentration of dentists. Dental hygienists are a little different. They tend to be more evenly distributed across the state. You still have your Franklin County with the lower amount, but a lot of states are in that, a lot of counties are in that middle area, that middle color. And I don't know why there are so many dental hygienists in Barnstable. That will be a good question to dig into more. And the last area that I mentioned was around policy. So our state, like many states, does have a current waiver with CMS, an 1115 waiver. And oral health is not comprehensively included, but it's important to note that the waiver does include one oral health measure, which is members receiving an exam within the measure period. And for the dental folks on the call, an exam is being considered a periodic, comprehensive, or less than 3-year-old exam. And recently, this measure also became a paid for performance measure for our ACOs, our accountable care organizations. So the exciting thing is that the medical side of our Mass Health program has been able to learn a lot of information. They have more measures in the current waiver, and we're hoping that all that knowledge and learning can be applied to the oral health community, and maybe this will be an opportunity for oral health to be incorporated in perhaps a more meaningful way in the next waiver or in a different way.
Matt, this is Rodrigo. I just wanted to give you a little time check
Sure.
that you have just a couple of minutes left
Yep.
before we hand it off to Meenakshi.
No problem. I only have like 2 slides left, I believe. So the portable dental providers, I just wanted to call them out as a growing group and an active group in our state. And public health dental hygienists operate with a permit M in our state. There's many groups involved in portable type dentistry programs. They are spread out across the state. Again, though, we do see central and western Mass have more zip codes not having an active portable dental program, shown as white there. And then it's important to remember about community water fluoridation as definitely a potential opportunity for improvement in our state. Everywhere you see yellow there are potential communities for improvement where there's a community water supply, but it's currently not fluoridated yet. As of 2019, we had 119 fully fluoridated communities and 19 partially. And as of 2016, Massachusetts was 38th in terms of state rank for populations receiving fluoridated water. So moving ahead and ending my segment, I think these are all important things to remember in terms of collaboration, innovation, as tools we can all use to improve health equity. And those are my references, and I'll turn it back over to Rodrigo. Just give me a moment.
Thank you, Matt. So folks may have some questions. Please feel free to enter them in the Q&A by clicking the Q&A button, and we will track them and address them at the end of Meenakshi's presentation. Or you can put them in the chat. We're monitoring the chat closely. What happens there is it's hard to keep track of all the questions. It's like a scrolling thing, but we're trying to address those as well as they come up. All right, so, one question that folks asked that I might as well answer now is whether or not we will be making slides available after. And the answer is yes, we'll be sharing slides after the presentation. So thank you very much, Matt, for that overview of oral health in Massachusetts. Now I want to introduce our keynote speaker. So Meenakshi Verma Agrawal is an associate professor of practice and assistant program director at Simmons University as part of their MPH program, Masters in Public Health. She is our keynote speaker for today, and she will be presenting on racial equity in oral health. Her areas of expertise include public health, organizational development, and racial justice. In addition to her role at Simmons University, Meenakshi is an independent consultant who provides trainings on how to lead with a racial justice analysis. Meenakshi, please go ahead and get started. Thank you so much for being with us today.
Thanks so much, Rodrigo. Hi, everyone, and welcome. We are so excited to have you here today. Just so you know, I teach a lot of my courses online, so I really spend a lot of time in this box, this Brady Bunch box that you're all seeing each other on. And even though it's not the ideal way that we would have liked to see each other, I am really glad that you're all here in this space together. I'm going to go ahead and share my screen, and so you can take a look at the slides while we're talking. And we're going to try to do things a little bit differently today. You know, it's hard to be doing this work in a webinar. You know, we're all imagining ourselves in, you know, some conference hall, having some warm coffee and, you know, maybe meeting our colleagues and, you know, just trying to be with each other in the same way that we have been before. So, you know, I just want to acknowledge that in some ways there is a lot of Zoom fatigue, and, you know, we're going to try to do some movement, do some chatting, do some polling to try to really get your voice in the room, because that's really important as we get started today. And as Rodrigo and Matt mentioned, I've been doing work in health equity for quite a while now, but what I'm here to do with you all today is to really give you an understanding of the shared definitions and a little bit more of the kinds of definitions that we're using. So in relation to oral health specifically. So as you all know, in relation to COVID, even before COVID, millions of people have struggled every day without access to oral health care. And for those without adequate dental coverage, many of the folks who are relying on our health centers, our federally qualified health centers, and our regular health centers, who now, because of this crisis, have had to change the way they do, you know, literally changing the configuration of their space, and some places have had to let go of the dental services, perceiving them as optional, which we all know is not really the case at all. And so we're limiting and already limited access to dental care. And, you know, once this crisis does abate, people will still have these inequities will still exist. So today we're going to spend some time, you know, sharing some common language that you can begin to use when you're talking about inequities. We're going to share some data and also end with some action steps. But as I was talking about before, in terms of our, you know, our time that we're in right now, I just want to share a tool that helps us acknowledge that, you know, maybe this isn't the way that we would have wanted to be together, but it is. And even in this space, we'd like to be together in whatever way possible. So the quote is from a professor of organizational behavior, and he said, "I spoke to an old therapist friend today and finally understood why everyone's so exhausted after these video calls. It's the plausible deniability of each other's absence. Our minds are tricked into the idea of being together when our bodies feel we're not. Dissonance is exhausting. So it's easier being in each other's presence or in each other's absence than in the constant presence of each other's absence." So just before we get started into yet another Zoom presentation, I just want to ask you to check in with your body and, you know, just see how you're doing and do what you need to do. If it's water or coffee or tea or whatever your choice is, make sure you're taking care of yourself. And obviously we cannot see you through your camera, so feel free to stand and stretch and do whatever you need to do so this can get into the body as much as possible. So let's start with our first assumption. Our first assumption is make the implicit explicit. And what we do is when we make the implicit explicit, we want to ask you what your identity is, not what you think the census, you know, what census box you check off, but what identity do you want to share with us in this Zoom room today? And how are you feeling about it? And so I'm going to put up a scale to ask you how you're feeling about it. So this is called a Baby Yoda scale. And what we're asking you is, on a scale of Baby Yoda, how are you feeling today? So sorry, I'm just trying to pull up my screen and also see the chat, but I'll just I'll just keep the screen on so you can see that on a scale of Baby Yoda, how are you feeling today? Are you number 1? Are you 2? Are you kind of tired? Are you number 4? Are you feeling kind of optimistic? And number 8. So what I'm going to ask you to do is in the chat box, I'm going to ask you to put this into the chat box. So if you can find the chat box, I'm going to ask you to introduce yourself with your name, race, ethnicity, pronouns, and how you're feeling on the scale of Baby Yoda today. So hold on one second. Let me pull up the chat and I'll plug that right in there and you can add it in there. So, name, so I would say my name is Meenakshi, my race is Asian, my ethnicity is Indian from India. I'm also an immigrant and my pronouns are she, her, hers. And the Baby Yoda I'm relating to today is, I would say like number 8. I'm kind of hopeful because the weather's nice and I'm kind of excited about it. So if you can go ahead into your chat function, I would love to see who's in the room. So name, race, ethnicity, pronouns, put them all in one line if you can so that we can see it all together. So then I'll just read a few off and then we kind of get an idea of where people are coming from. So Julie said she's number 6, so feeling maybe a little tired. Kimberly said she's curious and energetic. Oh, Matt's feeling a little low because his sound didn't work well. It's okay, Matt, we're really forgiving. Remember, we're all in this together. Tuha is feeling an 8. She's also hopeful. Let's see, Donna is feeling an 8 as well. Christine is 8. Ralph is feeling 2, so he's reaching up for some hope, I guess. Barbara is feeling an 8. Janet is feeling a 7. Let's see, Celia is feeling number 4, maybe a little tired today. Rhonda is number 3, a little anxious. Yes, we see you. Angela is number 8. Guadalupe from Mexico. Okay, awesome. Number 6, feeling a little tired. Let's see, Parisa is feeling 6, a little tired too. We got a few 8s and a few 6s I see here. So really great to see folks in the room and showing up and sharing how you're feeling about Baby Yoda. And as Rodrigo said, these slides are shareable. So, you know, I'm gonna share this with you. And if you wanna take this to your next staff meeting, oh, Parisa, I see you're number 7, that's fine. You can also change these whenever you want. It's however you're feeling at this moment. Arnaud is number 8, yeah, looking hopeful. Deb is number 7. Okay, so I wanna also share that some of the things that we're doing today are also tools that you can use as you get into this practice of doing some of these meetings online, because as we know, it's not easy to keep people excited and engaged. So this is one way to do it. Again, we have Angie, who's a number 8, and Melissa is also number 8. So again, welcome everyone. It's so great to see who's in the room. It was great to see Rodrigo's poll in the beginning, also to see, you know, which fields folks are coming from. So that's all very exciting. So this is just another tool that you can use to say, how are you doing? Bring it to your next staff meeting. It might kind of cheer people up. And I'm not a Star Wars person, but I know May the 4th was a few weeks ago. So I ended up using this in my classroom and the students really liked it. So hopefully you liked it too. And it's just good to get a sense of how people are feeling in the room. And we're gonna do that periodically over the time we have together just to see how you're doing, because I don't wanna just launch data at you. I wanna know how you're showing up. So great, we have a lot of great people in the room and I'm really excited about it. Okay, so I'm gonna move on from our slides just in the interest of time. So that was our first assumption, was that we will make the implicit explicit. We're always gonna name where racism is operating, because if we're talking about health equity and we don't talk about racism, we're missing a part of the conversation. So part of our framework is really imagining a newer type of world, right? I think many of us could not even imagine that COVID-19 would change our lives in such a different way. And I think the possibilities that are actually out there for us, for any of those who follow Naomi Klein and other activists who are talking about this as a tremendous opportunity for us to be able to say, you know what, the things that are happening, the inequities in our world are wrong, and we have an opportunity to change them. So what we're doing is thinking radically. We're thinking about what would a democracy look like? What would a radical democracy look like? And this isn't Republican or Democrat, it's radical in the way of like, how can we bring in and see all of those who are living with the most marginalizations and actually centralize our solutions and strategies based around that. What you will see today is that we're going to lead with racism explicitly, but not exclusively. So when I say we're going to lead with racism, people say, well, what about classism and what about sexism? And we always say yes to all of those, in addition to saying that if we don't look at it with a racism lens to start off with, we're actually missing a big part of the conversation. So what we want to do is look at the intersections between racism, sexism, classism, heterosexism, all of those. So if we're looking at people who experience the most marginalizations, our solution can actually be uplifting to all. We are going to talk about the head and the heart, and that's why we show, the baby Yoda, and try to really say, like, how are you feeling versus what are you thinking about this data, So we want a little bit of both to happen. So your head is engaged in the material we're sharing, but your heart and your body should also be engaged in the way you're feeling about it, because once we start to feel, that's what makes us be able to make change. One of the other things I'm going to do here today is critique systems. We're going to talk about racism as a structural problem, not about individuals having bad behavior, but about how structures and policies and institutions actually can perpetuate those problems without individuals doing bad things to each other. So I'm going to critique different systems, maybe the healthcare system, maybe the education system. I'm in higher ed. I have to constantly critique it, even though that's where I work. Because if we don't critique the systems and worry that people will take it personally, then we won't really get to the core and the crux of the problem. So we will personalize the critique. We want you to not personalize the critique of systems, which means, you may have a professor that you really love or a doctor that you really love, and we're not criticizing that individual person. We're critiquing the policies that are actually encompassing all of the kind of work that happens in those structures. But we do want you to make it personal. Why is this important to you? Why do you want to do this work? Why is equity and inequity important to you? Don't do it on behalf of someone else. Find your own why, and then make it happen. And so that's those two sides of the same coin, is that we don't want you to personalize the critique of systems, but we want to find your personal why in the reasons that it's happening. And then the last thing I'll say about our assumptions is that, we aren't operating in normal times here, right? And we want to offer each other as much grace as possible. If someone doesn't get right back to you for an email or a phone call, we know that many of us are homeschooling, living in certain situations that no one could have imagined before. So offer that grace, and that's something I hope we can do today here with each other as well. Just as in the beginning, I accidentally hit the broadcast button and opened it up to everyone before we were ready to broadcast. So we just offer each other and ourselves some grace so that we can continue to do the work that we need to do. So let's go to the next slide. So I'm also going to populate this with pictures of cute pets so that you can smile throughout the presentation, because I know that everybody feels good when they see pictures of cute pets, especially puppies. I'm not a pet person myself, but I do have 3 children, so that's a lot of work for me to take on any other living being. So so I'm going to share some definitions with you to start off with. We have, we really believe that if you want to start the conversation about racial justice, you have to have common definitions that you agree with, and it could just be you and your the person you work with in your office. It could be, you and your team members who have a committee together. It doesn't need to be the entire, dental association of a state, but it can be just you and a few people who are saying, okay, do we agree on the same definition of equity versus equality? Let's talk about it a little bit. So the first thing I want to share is that race is actually a social construct. So what that means is that there's nothing biological about race. In fact, there's more genetic variation between racial groups than there is within racial groups than there is between other racial groups, which means that race was actually constructed in this society and many other societies as a hierarchy and what you could call a caste system as well. And the definition of who is white and who is whatever identified as other races has changed and has been used to maintain political power, selective immigration, eugenics. Many of you may know it influenced what the Nazis did through their genocide. And so a lot of that originated right here in Massachusetts. So I think all of us who live in Massachusetts have a moment to really acknowledge the harm that's been done by this pseudoscience. So Johann Friedrich Blumenbach was one of the pseudo scientists that sort of discovered, claims to have discovered that racial groups were genetically different, but in fact, there's no such thing as a genetic difference between, as per your racial identity. Race is something that is socially constructed, which doesn't mean that race does not exist. So sometimes I've seen folks say, well, race is a social construct. Why do we keep talking about it? Well, racism is actually a system that has been put upon the creation of race as a social construct, and it's been used to change the definition of who is white multiple times in this nation's history. So there was a point in time in the early 1900s where Indian people were considered white until they decided, Supreme Court decided that they were not, and then suddenly everyone who had received their citizenship, it was taken away from them. So this is important. We're talking about this is because how someone is raced or racialized has everything to do with health outcomes and other outcomes as well, education, housing, where you end up getting your loans and how much your rates are. All of those things are tied into it. Okay, so Matt had talked a little bit about inequities, and I want to share another example too. A lot of times the difference between equity and equality is a confusing thing. So I'm really glad that we're having that conversation, because the word equity is used a lot. And I've often found that people aren't necessarily clear on the definition they're using. So if you can think about a time where you went, it's hard to imagine it now, but when we used to go to sporting events or concerts or, Disney on Ice or wherever you chose to go, when you saw that there was an intermission or the program ended, there was a long line in the restroom on the left side, right? And so what we observed is a long line on the left side and really not any lines on the right side. And the question I usually ask in this when we're in person is, who else is waiting in that line? So just in the interest of time, I'll just fill in that question for you. And then I definitely want you to participate in some of the other conversations we're having about this. So there's women with children waiting in line, there's elderly folks, there's people with disabilities, there's pregnant people, nursing people. There's a huge composition. There's people who don't see themselves on the gender binary, transgender people, all lined up in that long line. And equality would be that they created equal number of stalls on the right side and an equal number of stalls on the left side. But in equity would be that they actually designed the system for all of the people experiencing them, standing in that line, who are experiencing longer wait time and frustration. One of the best examples of this is an attendant of this training that I did before said, I saw an older gentleman with his elderly mother in a wheelchair looking at the bathroom signs and trying to decide where to go, right? Because oftentimes we have the largest stall is the one for disabled people, but that also has the diaper changing table, right? So there's all these ways that the design has tried to sort of put accommodations and say, okay, we'll make this fit for this person. However, it's really not working well for anybody. And the other point I want to make about equity is that while the people who use the right side of the restroom, probably went in and did their stuff and then came out, we all came in the same car together. So they're going to be waiting for us to go home. So the burden is greater on the left side of the sign, but it doesn't mean that there's no impact on the right side of the sign. So I think what you can think about is that everybody benefits from equity in the sense that, the American Disabilities Movement worked really hard to get curb cuts in the 1970s. And there's so many ways that people are benefiting from curb cuts right now. So if you can think about it in the principle of universalism is what John Powell says, or universal design, that'll think of designing for the people with the most marginalizations in order to increase equity for all. Okay, so that's an example, and we haven't even talked about racism yet. And I'll encourage you that when you do see this, get the slide deck, and if you've been wanting to have the conversation about equity with your team or with your business partner or anybody, then I would take the slide and start the conversation there, because I think folks can really relate to that idea of understanding why it needs to be equity and not equality. And this is a perfect example of that, right? We send some very specific signals about gender and racial roles when we don't put diaper changing stations in men's restrooms. And so this is a dad who's a single dad. He has 2 kids, and his older son's taking a picture holding the wipes, and his younger son's getting his diaper changed in this very hard squat. and he says, you can see how often I do this because my son is completely comfortable and relaxed while I change his diaper on my knees. So, I think that hopefully this helps you understand that equity is sort of equity will actually improve all of the outcomes that we often talk about if we start to think about who indeed is the most marginalized and who's experiencing the most marginalizations. And then I'll just go through some other clarifications, and then we'll take a quick check-in to see how you're doing. So you'll hear me use the term racial justice a lot. So it's not diversity. So we're not talking about diversity because diversity means variety. And perhaps diversity served its purpose for many years in terms of a term to describe a variety. However, the term has been co-opted as well. And I think a lot of people talk about diversity in ways like, oh, I love my neighborhood, it has really diverse restaurants. But when we want to have conversations about equity and racism, that conversation is largely absent. So, diversity is just talking about variety. It's not talking about power. And so that's why we want to really get toward that racial justice lens, is because it finally begins to talk about power. And then it's not equality because of the same reasons that we just shared a minute ago. So, and then this is the last part of this definition part that I just want you to think about a little bit, is that we also use the terms disparities when we're really talking about inequities, and I'll talk about why. Disparity is an inequality, and it implies differences between population groups. So it's actually unequal. So if I said that boy babies are born at heavier birth weight from girl babies, there's something biological about that usually, right? And so that's something that can be related to biology. But when I say that, at least here in Boston, Black and Latino babies have 3 times as poor infant mortality rates than white babies in Boston, that's an inequity. It refers to differences which are unnecessary and avoidable, but are also unfair and unjust. So I think that's a really important thing to think about, is that those kinds of inequities are actually avoidable. There's no biological reason that we should have those kinds of inequities here in Massachusetts, which is considered one of the, core medical meccas of the country, right? So it also exists here, and it's an important consideration when we're talking about what it means, what is the difference between disparities and inequities. So inequities really refer to the differences that are avoidable and unnecessary, and disparity just refers to like the differences between population groups. So what I want to share with you is that, if you've been to your provider lately or in the last 6 months, we've heard most of these things from our providers. We've heard them say, don't smoke. If you do, stop, eat a balanced diet, keep physically active. If you do drink in moderation, manage your stress, maintain social ties. Of course, this is very different in the life of COVID. So I'd love if you could chat me. This is a great list, and I don't fault any providers for providing this list, but what is it primarily focused on? What is this list primarily focused on? If you could chat me in the box what you think this list is primarily focused on. And Arnaud, yes, I will be sharing these slides with you all, and I'm not sure about I think it is being recorded, and they will be able to share that. Yeah, thanks, Parisa. Individual behavior, yes. Karina said behavior, yep. So individual behavior and not contextual influences from Georgia, yes, absolutely. An said emotional and mental well-being, personal autonomy, personal responsibility, what we can do to stay safe, and choice. So Celeste Terry said choice, and that's really important. Choice, this is implying choice, like we have a choice to eat a balanced diet. And if you lived in the neighborhood of Mattapan before 2016, you didn't have a full service supermarket there. So if a provider is saying that and not able to bring in the structure, yes, Ralph, it's all on you. That's what it's saying. It's all on you to make these changes. And what does that mean? It means that if you don't make these changes, that somehow you failed. And we're not really looking at the structures in our society and the institutions that are really collaborating to make sure that that doesn't happen. So we'll get into that in a little minute, okay? So let's go to our poll. I'm gonna go ahead and launch our poll. Hold on one second. And check in with you. How are you feeling? Are you engaged, alert, and processing? Do you need more coffee, tea, caffeine or snack. You're feeling distracted, but you'll bring yourself back in, and you're tired and drained. So I just want to check in with you, see how you're feeling. I know that it's hard to just hear lots of information being thrown at you, but I'm glad that folks are saying they're engaged. It's good to know. If you need your coffee, we're going to have a stretch break so you can get up and grab yourself some. But it's really good to see. And we have almost 100 people in this room today. That is so exciting. So yeah, please go ahead. We're going to just do the survey for another 10 seconds if you haven't had a chance to answer it. But you know, our goal is to really make sure that you can get as much of this into your body as possible so that when you go back to your organizations, you're able to take it with you. So I'm going to share the results. The good news is everyone's engaged, not everyone, but 57% are alert, processing, and engaged right now. So that's good. For the rest of you all who need more coffee and are distracted, but will bring yourself back in. And if you're tired and drained, I feel you, and stay as long as you can. And if it works for you, stay and take care of yourself. That's what I want to share. So we are going to take a 1 minute stretch break looking at a cute puppy. So as promised, I will show you pictures of cute animals, and it's so hard for me to not see your faces, but I hope you enjoy this picture. Take a minute to stretch and move your body around. You can get up if you're able to from your chair. If you cannot, then stretch in your chair, whatever's comfortable for you. But I'm going to set a timer for 60 seconds, and we're going to actually take full 60 seconds to stretch our bodies and come back into this room ready to work on more stuff with each other. Yeah, cute puppy, right? Thanks, Nellie. I also had feedback from people who like cats, and they said I didn't have enough cats, so I did put in the kittens for those folks too. So I hope you feel seen. Okay, just about 7 seconds left. And hope you can bring yourself back into the space now after a nice little stretch. And now I'm going to show you a quick video. So as we're beginning to speak about dental inequity, this is about 6 years old, and this link is in the presentation. But the Southern JP Health Center, where I'm on the board, and I do a lot of work with what's happening in their health promotion center, and if you have a chance, you should definitely check them out. They worked with a group of Black and Latinx youth, this was about 5 or 6 years ago, to work on a public health issue that they identified and felt was really important. So they actually picked oral health equity, and this is just a quick 2-minute video, which I'd love for you to see and get to know what these, that the work that these young men were doing is very similar to the work that you all have identified as priorities for you. So hold on 1 second. Oops.
Have you ever made the connection between structural racism and your teeth? Let's make some of those connections. Check this out.
Yo, we work hard. We're still poor. We have the right to our teeth. Just because we have mass health doesn't mean we should have fewer options.
Just because we're Black or Latino doesn't mean we should lose our teeth.
Just because pulling our teeth costs less doesn't mean we think it's the best option for us.
Somos inmigrantes, no merecemos ser excluidos de la salud dental.
Our children deserve better.
We want
fluoride in water since it's better for our teeth.
Because we live in Charlestown,
Roxbury.
Dorchester.
does not mean we choose your dentist. We 4,000 people.
Talk to your representatives and community leaders. Join any of the following organizations working on policy change. And don't forget to brush and floss.
All right. So I'm sorry about the subtitles on that one. Some of those were very not that great. We have much better closed captioning and subtitling here. So thank you to Stephanie who's doing that. So yeah, so what, just why don't you chat me a few thoughts that you had while seeing that video? What do you think about the work that these youth are doing, and what are your thoughts on seeing the video? Is any of that information new to you? What do you want to share about that? Why don't you just pop some thoughts into chat? And if any of you have seen that video before or videos like that. Okay, great message. Medi-Cal clients in California have the same experience. We see a lot of the same concerns in Connecticut. Would love to see a campaign like that. And yes, it addresses systems and policies rather than individual behaviors. Yeah, thanks for that, Rodrigo. I agree, is that all of those things, I think the goal of that message was really to say that, looking beyond what individual behavior is and thinking about how policies are actually, the way that, dental services are funded in this state and, all over the country. It makes us really think about, why isn't dental care universal? That was the first thing I thought when I saw this. Yeah, and Nellie said it relates to a lot of the questions patients ask while asking them of their needs and social determinants of health. So this is her first time seeing their first time seeing the video. So thanks for sharing that, Nellie. And you may have other thoughts as you see some of the materials, but I just want to share this, that this is a good way to get youth involved, because I think also youth are experiencing many of these inequities themselves. So they see that, and then they see themselves represented in a way, and that seems really, really important. So yeah, the same issues in oral health are, even worse as we see issues in oral health are allowed to go on even longer than issues in health in general, right? And so I've always wondered, how oral health was never integrated, but I'm sure there's a long history of that reason that someone could possibly share someday. All right, so let's move on. Matt shared a lot of these statistics, so I'm not going to just spend a lot of time on them again, but I think oh, Linda's here. Oh, hi, Linda. The price of paying for oral health out of pocket is tremendous, and many neighborhood dentists who are not from the neighborhood take advantage of parents who are in pain, patients who are in pain, trying to convince them of work that they don't need. Oh, that's also a thing. Yeah, absolutely. Buying insurance is out of pocket is expensive. Absolutely. So let's talk a little bit about this. So national oral health inequities data shows us that, something that's not surprising. It's kind of, as my colleague Abigail Ortiz says, water is wet research, that we know that the greatest inequities are really felt by those who are most marginalized, historically most marginalized in our country. And so non-Hispanic Blacks, Hispanics or Latinx people, American Indians, and Alaska Natives generally have the poorest oral health of any of the racial and ethnic groups. They have the greatest tooth decay is also with children from communities of color, and as is the adult and untreated tooth decay between Blacks and Hispanics, and Blacks, non-Hispanics, and Mexican Americans aged 35 to 44. So, this is really important, right? We know this data, we think about this data, and yet when it's in front of us, we kind of struggle to find ways to talk about it differently or to engage the correct stakeholders to help us advocate why dental care should actually be fully funded, right? Yeah, Donna, thanks for sharing that Teeth by Mary Otto is a discussed as a great divide of oral and general health. Okay, that's good to know. Thanks for sharing. And just so you know, the chat is saved, so we can also try to pull some of these resources that you're sharing in the chat. An said, pulling teeth is fully reimbursed, restorative work is not, so there's an inequity right there. And the safety net locations info is not easily accessible for an average person. Absolutely. So these are all ways that it shows up, right? Okay, you can pull a tooth, but what does it mean to preserve that tooth, and who gets the access to be able to do that? So let me share this, these are things that Matt went over. So no surprises here in terms of dental visits. Also seeing that income is a factor in it. So income, race and ethnicity, ability, education, and then of course ability pays into it, right? How many of these places are accessible for people with disabilities, and what does that mean for their oral health to be even further damaged in addition to the challenges that they have with their general health? So this is really important, and we really have to think about it. Okay, Susan just shared that the breaking of teeth due to meth use is also a large problem. So restoration due to addiction is also an issue. So these are all things that I'm sure all of you are seeing and dealing with in your various practices, and that's really important for us to know too. Appointment times, inequity in oral health can influence their ability to earn money, right? So imagine going to an interview without front tooth, as Linda said. So absolutely, these are all such helpful pointers, because when we look at data and we just say, oh, okay, look, looks like people who don't make $25,000 a year only are going for their dental visits 60% of the time. What are they doing? They should just be maintaining good oral health. And we find a way to explain it back to behavior problems, right? But we're not talking about the system that reimburses at lower rates, or the availability of safety net providers, and like how pulling a tooth is fully reimbursed versus repairing it. So we have to always ask why when we see data. Otherwise, we're continuing in that cycle of making assumptions over and over again. And that's the last thing we want to do, especially after you all spend some time with me. So I don't want anybody making assumptions. And that's why we spend so much time being explicit with each other right up front. So again, this is the education levels and then abilities, as we talked about. So let's get back to the chat and tell me, what are you hearing about inequities and COVID? So we're not talking about dental inequities yet. We're just talking about how are the inequities showing up in COVID-19. So why don't you just go ahead and chat some of those things? What are some of the inequities that you're hearing about with COVID-19 and how it's having inequitable impacts on different communities? I'd love to get your thoughts in the chat. What are you hearing about it? Georgia, thanks for adding. Missing school, nutrition, yep, okay. From Susan, Chelsea was hugely hit, big infection rate. Families who depended on schools for breakfast and lunch are missing out. African Americans are not able to get tested. The last neighborhoods to get decent testing is in Black and brown neighborhoods, higher rates in poorer communities. Testing is largely unavailable. Working versus staying at home with children is difficult. Yeah, we're hearing people aren't sharing. Latinos are more likely to be infected. And that's also, there's a why reason for that, right? We have to talk about that. Absolutely. So let me share some of the headlines I just grabbed recently when I was putting together this presentation. Lack of digital inclusion, absolutely. Inability to distance learn. Race, ethnicity based on inequities in testing. They're more likely to be frontline essential workers. Parisa just said that, absolutely. Is there any correlation between those who don't receive dental care compared to when adult coverage is decreased or expanded? That's a good question. African Americans have higher rates. Let's see. Oh, okay, Shalini, okay, hi. It's hard for people who live in densely populated communities. It's harder for them to social distance and quarantine, absolutely. Patients already with limited access to care have comorbidities, which makes it higher, their risk higher. Anila said high death rates of African Americans due to previously existing health inequities, I would say, due to structural racism and historic redlining in this country. So let's talk about that a little bit. Thanks for sharing your thoughts, everyone. So yeah, so the Boston Medical Journal just shared that, you know, COVID-19 is the painful price of ignoring health inequities. What's happened is that we've ignored health inequities for so long, and COVID-19 has just really amplified those inequities. We also see that it highlights longstanding health inequities in the US, but also in other parts. And there's lots of articles out there about, you know, a conversation about racism, health inequities, and COVID-19. So what you're seeing here is something that we pulled from the Boston Public Health Commission. This is in early April. So really before, at least for Massachusetts, it was before all of it went in the direction that, you know, we're currently in right now. So why don't you chat me what you observe here? Like, where are you observing the highest rates than the rest of Boston? And also, when you say the highest rates, say the why. Why do you think those neighborhoods are experiencing higher rates? Let's see what your thoughts are here, because what I want to do is, because when Dr. Fauci went up and spoke about African Americans being at higher risk due to existing disparities, he failed to say the why, right? He failed to say that this is due to historical structural racism and redlining in our country, and that's actually led to that. Okay, sorry you can't see it. This is, I can try to go full screen. Here we go. This is better. So what do you observe about it, and why do you think that that's the case? And then go ahead and chat us what you think. What do you observe, and what's the why? Okay, now I can't see your chat, so I'm gonna have to take that off full screen, sorry. Let's see. It's challenging exercise for the, okay, sorry, this is a challenging exercise for those not familiar with those neighborhoods. So this is a map of Boston. And I'll let your colleagues who are in the room share a little bit, and then I'll explain a little bit more. So Chelsea density, which is up here, is much higher. Many hourly employees, essential workers in supermarkets and delivery. They're historically low income communities. Dorchester, Mattapan, Hyde Park, East Boston, exactly the reasons: historical and cultural, current systemic racism. Let's see, large communities of people of color, hard to isolate in tight residential quarters. Yeah, so I think Deborah said it, and I think it's very common. You can really see this in maps all over the country, is that you see that where people are working largely as essential workers, which means you know, the folks that are service staff in hospitals, folks that are working in the grocery stores, delivery people, all of those people are, or the majority of those people are living in these neighborhoods that are the darkest. And they also use public transportation. Thank you, Christine. Yes, people are using public transportation. They rely on public transportation, could be transmitting that way. So the problem is that when we show a map like this without saying the why, we go right back to that personal behavior, you know, list that I showed you right at the beginning of this, right? Oh, why are those people not, you know, wearing their PPE, or why are they not, you know, having more practices where they're socially distancing from each other? Well, the answer is that the system has been set up in a way that they're not able to at all, right? And so then we see the rates that are higher, and then we try to come up with, you know, ways to fix the problem now, whereas the challenge is that we never address the problem to begin with. Because you can look at this map and see that this is also the highest rates of asthma, this is the highest rates of homes in foreclosure, this is the highest rates of chronic disease. So it's basically like you pick a health inequity and you can place it there, and it has a lot to do with where people live and work. Because the Boston Public Foundation has also, the Boston Public Health Commission has also shown a map that shows us where people work in arts, business, and science in Boston. And you could say that it's almost a complete inverse of this map. So if you live in a place, if you work in arts, business, and science, you generally might have the ability to work from home. You may not have to go in on public transportation. You may have access to all of these ways that you're actually self-protective or protected, versus going in and risking your life for your job, which, you know, this whole idea of who's an essential worker has come into question a lot. And as Linda said, we're still working on emergency interventions now, of course, because the crisis is right in front of us, and versus thinking about prevention from the get-go, right? So those are important things, and I appreciate you sharing that. And I want to just remind you that we do still have to get historical, right? And so for those who don't know Boston, this is called, this is a residential security map, and it's a map of redlining. And so for those who don't know, I didn't know this until very recently, and I grew up and went to public schools and my whole life, is that there was this concept of redlining that's happened all over the United States. And it was a way of systematically where the banks worked to really disenfranchise business and home loans for primarily communities of color, but I will say poor white people were also impacted by that. So that what you see is that the connection between the COVID map or the asthma map is all in line there. Sorry, I'm gonna enlarge the screen again, sorry. This is a small map anyways, but what it shows you is that the same communities that you saw that had high rates of COVID are also the communities that were redlined out of opportunities. So economics and racism and structural racism and environmental justice all go hand in hand when we think about what happens intentionally by banks. Now, if this is something you're interested in, you can also go to mappinginequality.org. It's an organization, and they actually show you the maps from these cities everywhere, all over the country. So you may be able to find your city, and then if you can make the connections between, the health issues and the ways that it was redlined, that's an important connection to make, because I always say that, and this is what Dr. Kamara Jones says, who was a former APHA president, and she's a professor of public health practice. She's an amazing, she has a ton of YouTube videos and TED Talks if you want to learn about the way she talks about structural racism. She says that we've become so ahistorical in this country. Like, we can't talk about COVID-19 impacting communities right now if we don't talk about what's happened historically in this country. So those are all really important things to keep in mind when we're having these conversations about structural racism, because otherwise we look at data, and I think in public health and oral health, we have to get better about this and saying that this data didn't just happen because, this data isn't what it is just because of what's happened in the last 10 years or 15 years or even 20 years. We have to really make sure that we're going back and saying this map was created in 1938 and we're still seeing the ramifications of intentional and structural racism. So I wanted to bring that up for you guys, for you all, because I think that that's an important part. So when someone shows you data, always make sure that you're being explicit, and always make sure you're being historical. And that would be, if you take away anything from today, is saying that we cannot show data without the why. And the why is asking why is history impacting this, and why is structural racism impacting this. Okay, now we have a stretch move. So if everyone can get up, you don't have to dance like Carlton, because frankly, I think I could injure myself at this age dancing like Carlton, but please get up, stretch your body, move around. You're gonna have 1 minute to move around, and then we're gonna come back again and go into the next part. So please at least stand up from your chair and move around a little bit. I'm gonna shut off my camera and do that, and then I'll be right back. All right, hope you're stretching. All right. Okay. You can find your way back to your screen, and this guy keeps moving, so when you get this presentation, you can also use that. I just love him. He's just so happy. All right, so let's go to our definition. So you may realize that we haven't used our definition. We haven't said our definition yet. So what is racism? So there's lots of definitions out there. I know people may use different ones themselves, but we use the definition, a system of advantage based on race. And this is by David Wellman, who wrote a book called Portraits of White Racism. And this is important because we really want to talk about there is also advantage. We always talk about racism as always a disadvantage, which there is, and that there are people being advantaged from it, right? Because it's kind of like when we speak about how emergency room visits are costing us so much money. But we're not really talking about who's benefiting from the emergency room visits costing us so much money, right? Someone's actually profiting off of that. So let's also talk about who is the system advantaging, and why is that? And I'll clear that up a little bit more in the next screen. So these are the 4 levels of racism that I'd love for you to just chew on a little bit as you're here with us. There's 2 levels of internalized, 2 levels of micro, which is internalized, which is really manifests differently for white people and people of color. So the internalized is really, for white people, it's what is normal, right? It's this idea that there is a superiority, and that's not talking about, you know, the supremacy that we assume, like, you know, the KKK or whatever. It's really about this belief that because I can turn on, as a white person, you can turn on your TV and see people who look like you. You can read a book and the characters will be like you. You can go in a hotel and the shampoo will be for your texture hair. Is that is just the baseline and the normal. And while many white people I know are not walking around saying that they're superior or better, it's just sort of baked into our system. And so that's how it gets internalized. And the reason we have this picture of family is that if you Google family, at least here in Massachusetts, this is what pops up. And so, you know, for many people, they don't see their family in this. And if this is what your family looks like, that's totally beautiful. But it's the idea that, you know, 2 parents, 2 kids, you know, looks like the dad's going to work, the mother's, you know, in her pajamas, there's like a full meal on the table, no one's running out the door, like, you know. So if you can't see your family in that, and knowing that that's the normal, it ends up being what everyone's aspiring to, and frankly, it's not correct for many of us. It doesn't reflect what many of our experiences are. And then for people of color, this is also internalized because subsequently, whiteness becomes aspirational for many of us, and then we begin to believe the stereotypes that are out there about our ethnic and racial groups. And frankly, for people of color, this is how we end up taking each other down, right? Because there's this idea of this sliding scale of being able to get closer to whiteness as a setup for success in life. So that's one that I think requires a lot of individual work, and we won't spend a lot of time talking about that one today. But the interpersonal one is the one we see the most, right? We spend a lot of time in the interpersonal, like this person was, you know, doing this caught on video, in the sense of, like, you know, reporting kids for selling lemonade, or, you know, someone just coming out of, you know, wherever and saying something really like a racial slur or a sign, or even on the internet, like whatever you're experiencing, that's the interpersonal. It's between individuals. But the macro level is where we don't really go often. And so I want to talk about that a little bit. Institutional racism is harms, yes, thanks Georgia for putting in the structural one, systems, practices, and policies. And institutional is really getting to the institutions that are perpetuating racial inequity, and oftentimes without intentional harm, at least now in the time of structural racism. Like, I work at a university, and we have this idea of unpaid internships. And you know, at the first look, unpaid internships would be a great idea, right? Who wouldn't want someone to have a little bit of work experience before they enter the work world? However, you know, who is able to afford to do an unpaid internship, right? If you have generational wealth, or someone's putting you through college, you don't have to work your way through college. That already creates inequities that are setting up some people to have more advantage than others, right? And so there's ways that we end up creating harm, even with the, you know, best of intentions, as we could say. But there's other practices, like the disciplinary rates and the inequities there, where, you know, children of color make up a smaller percentage of the population, but make up a larger percentage of those who are disciplined in schools. And there's hundreds of examples in healthcare and housing. And so we're just talking about individual institutions there. And as Georgia said, structural is really all of those institutions, multiple institutions working together, creating policies and practices over time. And so this would be what we call the system of mass incarceration of men of color, so or Black and Latino men, to be specific, is that it wasn't just the prison system that had to be down with that. We had to have banking and lending, we had to have school system, we had to have bail bonds, we have to have housing, because if you have, you know, a conviction against you, you get kicked out of housing. So all these institutions are colluding, and then that creates what is what is seen as structural racism. And it's almost the hardest to see. And I think it bums all of us out when we realize that structural racism is actually everywhere. I mean, that map of redlining is actually an example of structural racism, but so is how we pay for schools because of tax systems, and how are those tax codes set, who's setting them. And so I want you to just keep that in mind, is that we spend a lot of time in the interpersonal, but we spend very little time in the institutional or structural. So let's keep that in mind, is that, you know, anytime you want to have a conversation or you want to bring some of the slides of this and you're worried that people will say, well, I'm not a racist, like, I don't want to be talking about this stuff. You can say, well, we're not talking about individuals at all. In fact, we're talking about structures. And I think people, once you start talking about the structures, folks are really able to relate to it in a different way, because calling someone a racist is really not our end game. It's not going to get us anywhere. It doesn't change policy. It doesn't change structures. But naming structural racism, naming the history, saying where it's operating, being explicit, all help us get to that change. Okay. So this is like, if we had to rewrite that tips for staying healthy, this is funny, not funny, but if we really had to say to people, instead of changing individual behavior, we'd say, don't be poor. If you can, stop. If you can't stop, then try not to be poor for too long. Don't have poor parents. Don't live in a poor neighborhood. And that would seem weird, but you know, if your parents own your house, you have more of a likelihood chance of going to college. There's like data on that too. So, you know, there's so much that they're saying here that we don't actually say. So what would it look like if we as practitioners and providers were able to not say this directly, but we're able to really acknowledge how the structures actually determine our health a lot more than what I would say are the social determinants, but our structures, our structural determinants are an important part of how our health outcomes actually look. So let me share a few more examples with you, and then we're gonna, we can do another chat to see how everybody's doing. So a lot of times folks list race as a social determinant of health. So you'll see this list of education, job opportunities, socioeconomic status, etc. And then race will be listed at the bottom of it. We are starting a movement to say, let's name where racism is actually operating. So let's call it racism, because having a race, as we said, is a social construct. However, racism influences all of these social determinants, which in the end influences your health outcomes. So racism impacts the education system because we're seeing disproportionate disciplining practices. That impacts your health outcomes. Racism impacts job opportunities. There's umpteen studies of like blind resumes, names changed to sound as of different ethnicities, and you see that there's different outcomes in terms of who gets the job. That results in poor health outcomes. Same thing all the way down the line. So it's an invitation to name racism and stop saying that race is causing it, but racism is causing it. And then you can also, of course, be intersectional and say, and that includes classism, heterosexism, sexism. So if you're a trans woman living in Dorchester and you're unemployed or undocumented, you're experiencing many of these social determinants or structural determinants at the same time. And of course, that's influencing your health, your education, your housing. All of those outcomes are happening all at once. Okay, so let's just talk about it across, because we've been talking a lot about health right now. Let's talk about it in other systems, right? So we have racial inequity persisting across every system in the country without exception. So this means that, you know, white people are doing the best, Black and indigenous populations are doing the worst, and then Latinx and Asians are faring somewhere in the middle depending on how they're racialized, right? So in child welfare, we call racial inequity called disproportionality, which means the number of children that are in some kind of case engagement with child welfare. Health, we call it health disparity or health inequity. Juvenile justice, we call it disproportionate minority contact, which means the number of times a youth of color will come into contact with police before their 18th birthday. They have names for it, you know? And so in education, we call it the achievement gap or the opportunity gap. In housing, we have whole, government agencies set up to address housing discrimination. And in economic development, we call it historically underutilized businesses, right? And I always say underutilized by whom, right? And so tell me if you go to the chat, what is the problem, if any, in having a different name for structural racism in each system? So tell me what you think is the problem, if any, for having a different name for structural racism in each of these systems. And if you don't think there's a problem, then tell me why too. Hard to measure. Irina said, hard to measure the impact consistently. Absolutely. How do we know what's working? Teresa said, avoids naming racism, creates confusion. Donna said it minimizes the problem. Kimberly said it divides the responsibility. Susan said it allows structures to be coy and stay broken. Yes, absolutely. There's no common definition. Let's see, that's what Christine said. Jill said it's hard to keep up with all the different terms. Yep. We may not be clear what we mean when we say X or Y. And Matt said, provides an easy way out. And Linda said, it's a way to blame each other and not solve real problems. Absolutely, right? How? Yes, Kimberly said creates silos. Jennifer said makes it confusing. So there's all these ways that we're not really having the conversation that we should be having. And, you know, I will say also implicate our educational system in this, because now I'm in higher ed, I can critique myself, is that you can get a PhD in disproportionality, you can get a PhD in health disparities, but you can't get a PhD in structural racism as of now. I'm not sure if anyone has started offering it. And the other thing is that if you go to a funding agency, for many of those who apply for grants, you know, you are unable to get a grant to address structural racism, but you can get a grant to address the achievement gap. So there's all these ways our structures and systems are tied into this and prevent us from having real conversations, because this can all be called structural racism in child welfare, structural racism in health, but when we give it a different name, we're actually coding it and we're not really having the real conversation. So we're definitely going to get to questions, and I'm about to wrap up, so we'll definitely have time for questions. Maria said, because laws are not reinforced, some people who get to power get comfortable and it's hard for them to speak up. And I do agree. And I think it's not just up to people of color to be speaking up about this, but if people who identify as white also see that racism is operating here, it's historical, it's structural, then we all have a duty to actually speak up with it, because we are all in the same system. So I'll just share this example, and that this last chart was from the Racial Equity Institute, and they're doing a lot of great trainings coming up online as well. It's an organization based in North Carolina, and they do 2-day trainings on structural racism, and they have a powerful historical analysis. So I encourage you to reach out to them. I'll just chat their name for you, and then I'll also share that when we send out the slides. Okay, so Racial Equity Institute. And so the other story that they share is that we're really good at fixing fish. So if Rodrigo lives in a really nice house and he has a pond behind his house, and he goes outside and he finds one fish floating belly up or barely surviving, his public health training may train him to like take out the fish, maybe do a little CPR on the fish, or try to get it, you know, back into health, because, you know, public health is often about fixing individual behavior change. And I'm just using Rodrigo as an example. And then we have An, and An lives right next door to Rodrigo, and her pond also has fish floating up, belly up dead. And then we might say in public health or other systems, like something's wrong, there's fish here, there's fish there, maybe we should check the water. But then we see that, you know, Stephanie also has a pond with her fish floating belly up dead, and Georgia has a pond where the fish are floating belly up dead, and then we're beginning to see a pattern. And what we say at that point is that it's actually in the groundwater. So if we can think of structural racism as a groundwater problem, like 90% of the water on this earth cannot be seen. That's why we're so uptight about the water table, right? So if we can't see the groundwater, then fixing these fish in these individual ponds is actually not going to get us to the solution. And the same thing with structural racism. We could fix the health inequities, we can fix the opportunity gaps, we can fix the housing discrimination, but the disproportionality, the disproportionate minority contact are all still going to be there. And then what are we going to do about that? So we say that, you know, we are really good at fixing fish, and what we really need to do is get to the groundwater of the problem. So I want to just share this great resource. An shared this with me yesterday, and I thought that this was a really great way for us to begin to summarize, you know, what can we do in this moment? What do we need as people working in dental equity and dental health to really think about this unique moment that we have, and I would say an opportunity because of COVID-19 that's been presented to us to actually begin to really make changes in what the future of dental care actually looks like. So I've put the link here for you to explore that also. But looking at universal and comprehensive dental coverage is really important. Medicare should include full dental benefits, something Medicare for All actually proposed to cover. we need to push back when we have a chance to cut back on adult dental, because this results in more problems in the future, as well as childhood dental services. We need to expand the dental workforce and expand the role of dental therapists. This was a helpful response from what they were saying. Yes, okay, Melissa's a dental therapist. She's clapping her hands to the dental therapists, because there are ways that those folks are able to reach harder to reach communities, in the sense of, you know, when we looked at that video earlier from Get Hip, they were talking about the lack of safety net providers for these large populations. And so I think that that's really important for people to really think about, is that how are we expanding the role of dental therapists? Also thinking about people who live in those communities. How can we put the money back into the economy that's there, not transporting people in from other places, but training people there to be able to provide dental therapists. So, oh, great. Sherry said, Illinois just passed public health dental hygienists, would love to have dental therapists in Illinois. Yeah, so, you know, we really need those. And I think that that would really just make, there's so much work that would really just make the work so much easier, right? And the last thing I'll say is that we would improve access to and increase payment for teledentistry services, right? I mean, how many times for many of us has been actually going in for the appointment been harder than actually dealing with the challenges of the issue that we're having? And so, and I know that in general healthcare, we are tapping in a lot more into telehealth, and there's no reason that this shouldn't also happen in dentistry. So these are my 3 main points, but you should definitely click on the article when you get or I'll just put it into the chat after this, but it's a really great tool to take with you. Speaking of tools, I'd love to chat us one of the following. Oh, okay, Catherine shared legislation is pending in Massachusetts to establish dental therapists. So support that. Get out there, put your voice behind it. I think that'll be really, really important. So chat us one of the following. What's the one thing on your mind? What's the one thing you might be taking with you? And what do you want more of? Like, what do you want to learn more about, or what would you like to do? Is just chat that in there, and then we'll wrap it up and we'll go to the Q&A section. So I'd love to hear what's something that's on your mind, something you're taking with you, and what do you want to do more of, or what do you want more of? Okay, Sherry said, increased access for those on Medicare, knowledge sharing. Are there any success stories or models that can be shared? So Donna said. And Catherine, yes, I agree on knowledge sharing, absolutely. What will teledental care look like? Yeah, Linda, that's a good question. Catherine Perry said preventive care for mass health, absolutely. We'd like more, Deborah said we would like more information on current successful programs. So who's doing this and who's doing it well? I mean, there has to be, I'm not familiar with that, but I'm sure between Rodrigo, Matt, and others would be, and Ann would be able to provide some of those answers for you, absolutely. What else is on your mind? More data on inequities for targeted interventions. Okay, Ravi, that's helpful. Oral health champion, Celeste said. Okay, Susan also said, I want successful answers. National licensor. Taking it all with me. Thanks, Karen. It was great to have you. Hugh said, how can medical and dental work together to address inequities? Yes, yes, yes. Triple thumbs up to that in education and practice. If teledental becomes the thing to do, will the poor neighborhoods be primary recipients if it's cheaper? Oh, that's a really good question. Let's make lemonade of COVID-19 and use this opportunity to reset and rethink all we do to improve health equity. Yes, Kathy, thank you. That's a great way to look at it. Linda, yeah, that was a great question. If you know, what happens to the poor neighborhoods? Will it be cheaper with telehealth? An said for statewide structural change, keeping the legislators constantly updated of the inequities and funding needed geographically. Getting stakeholders on board in Massachusetts is challenging, yes. Teledentistry saves PPE costs, yes, Sherry, you're absolutely correct. Deborah is talking about the importance of the spread within the medical system, absolutely. Hugh said, I'm finding telehealth is allowing me to get to patients that normally have many hurdles. We need to keep some telehealth, absolutely. All right. Well, I'm going to hand it back over to Rodrigo. And I just want to say thank you to all of you. It was so wonderful just to hear your voices in the room. But I mean, I would love to see you someday. So hopefully our paths will cross. But I want to really thank you for an engaging discussion. We actually would love if we usually do a dance together. And so if you, after this session is over, please do click on I Can See Clearly Now by Johnny Nash. And please do a little dance to move your body. So thank you, everyone. I'm going to pass it back to Rodrigo.
Thank you so much, Meenakshi, for that wonderful presentation. I hope everyone can hear me. We are keeping track of some of the comments and questions that were raised, but I also want to give everyone a little bit of a chance to enter any questions that you have for us to address in the 15 minutes that we have left. Please put them in there. You can put them in the chat box too. But the Q&A is a little easier to manage.
Oh, okay. I can answer the, have we seen success examples in addressing structural racism? Susan asked that question, and yeah, I mean, I think there's lots of examples of us trying to do things a little bit differently now. And I think, you know, the answer of structural racism actually looks like, you know, the Fight for 15 or, you know, housing rights, or, you know, even this idea of fighting evictions during COVID-19 is an idea of battling structural racism, because at the end of the day, because of history, because of, you know, who was able to build wealth in this country, you know, is definitely not people of color, you know, who has access to savings, who has access to a house that they own, that they can, you know, pay the mortgage payment or even ask for abatement. They look like those kinds of policies. They look like Medicare for all. They look like the Fight for 15 or legal living wage. They look like those kinds of solutions, which are actually more universal, and they actually help everyone, but they help people who've been marginalized for, you know, over 400 years of their generations a little bit more. So I hope that answers your question. But there's also other examples of organizations who are being explicit, and I'm happy to share that. And frankly, there's a lot of great work happening at the Department of Public Health as well. So I'm sure Rodrigo and his team could also speak to that as well. Yeah, Susan, it starts in the grassroots often, right? Because it's hard, I'm not sure, but I would say, like, there is a movement happening in government, right? With Ayanna Pressley from Massachusetts, Alexandra Ocasio-Cortez, like, all of them are beginning to speak about structural racism in a way that I have not heard in the legislature before. So I think that there's real progressive work that's happening both in the grassroots, but also on the legislative level right now at this time. Let's see. Diane asked, considering the map about many communities without fluoride, I'd like to see a future campaign aiming to increase community level in fluoride. Any other questions? What else is coming up for you all?
So Meenakshi, there are some questions that have been answered, but I think they're worth just reading out loud for folks.
Yeah.
So Hugh Silk asked, are there plans to coordinate teaching our dental students about health or oral health equity? And the same for teaching medical and nursing students about oral health equity. Well, Matt answered that, but
Right.
also left it open because, well, and you being an academician and actually might have some information to add to this, that there probably isn't enough of an understanding of social determinants that is currently required as a competency for graduating from dental institutions or pre-doctoral students.
Yeah.
Do you have anything to add?
Yeah, I will say that, you know, more and more, we have a student that's in our program, in our MPH program, that is, she's already a physician, and she's working with a medical school out in California to incorporate more social structural determinants of health as well as racial equity work into the medical students curriculum. But I will say largely it's absent. And in fact, much of it is still wrong in terms of saying that there are genetic differences between races. And that's the problem. We still have, you know, correcting for kidney function in our medical community. We still give different hypertension medications. And that's the problem, is that the research has been predicated on it. And so that's something that needs to be repaired in our system. I will say that, you know, and I think the medical hierarchy is hard, because I've seen residents come to our trainings and say, I really want to speak to this, but my attending is like the person who's like going to give me a recommendation after this, I can't really push that boat too much right now, but we'll do that when I get into my own practice or whatever they're doing. And so I think that is a challenge for many providers. But I will say, like, we have a big nursing school at Simmons, and I've connected with some of the professors there, and they are trying to bring in a little bit more of a lens, but it is challenging. And I'm not familiar with the dental education system, but all I can say is that it's lacking in every part of our education system right now, even from elementary to all the way through professional degrees. So I think we all have to grow, and some of that learning has to happen on our own, but it would be great if structures were able to provide that. So Ravi said, can you comment on how one can address oral health inequities, say, for example, access to oral health care in a dental provider shortage area? Do you want to, well, I think one of the things was, advocating for dental therapists to also be a part of the work that happens in communities, petitioning legislators to support community health centers also providing oral health care. So if those locations have oral health, have health centers or federally funded health centers, are there ways that they can also provide oral health care? I would say, like, really petitioning for it, but maybe Matt might be able to speak to that more on how one can address oral health inequities, say, for example, access to oral health in a dental provider shortage area. Matt, do you want to take that?
Sure. I mean, I can't really speak to specifically advocating for one thing over another.
Right.
I can say that the answer might lie in workforce innovation, for example, and various policy changes that could support that activity to help address the problem. And also trying to connect to existing resources that maybe people are unaware of within the existing care system.
Mm-hmm. Yeah. Great. Any other questions? I know we're right about at time, and so I'm always hesitant to force people to sit longer than they need to, but hopefully you've been moving around. And the slide presentations will be available, and the recording will also be available. So I'm not sure about the timeline of when that'll actually happen, but those are promises that we can say that we are making, and happy to share that with you. And I want to just make one last announcement before I finally pass it back over to Rodrigo to close us out, is that as I mentioned, I'm at Simmons University. We actually have an existing online MPH program that's been in existence for about 3 years now. And if you've always, if you found this presentation interesting, this is what our MPH is all about. So if you ever wanted to go back to school, I would say we are also giving out $20,000 scholarships right now, which will ease the burden of anyone who wants to come back and do their graduate work fully online over 21 months. So I'm going to also put the link into the chat box for you. So you can also reach out to me if you have any questions about doing your MPH or anything in this presentation that you want to connect on. I'm happy to be there for you. Okay, passing back to you, Rodrigo.
Sorry, I was muted.
Oh,
Sorry,
okay.
I was muted.
I'm like, oh, everyone's gone.
No, we're here.
Okay.
So as people are logging off, I just wanted to thank all of our participants and also thank our presenters.
Oops.
And also wanted to just give a little mention to all of the folks who are part of the OHEP team, as well as our OHEP community partners, who I think to the point of some of the questions that were raised about addressing some of these issues, and we'll be hearing more about this during our last presentation when we give a more in-depth overview of the OHEP, but that it really is something that we're trying to address across different service systems. Meenakshi mentioned how different service systems touch some of the different populations, and that's one of the things that we're trying to address, is to break some of those silos and work across service systems. I also just wanted to say, I'm sorry, one second, I will get back to Zoom here. Just wanted to, this is not popping up. Aha. I'm sorry. Well, we are at time, so I just wanted to thank all of our participants. And I'm sorry, having technical issues. What I wanted to say is that these sessions that we have lined up are going to be every week on Friday, starting at 11 a.m. for the next 5 weeks. The next presentation that we have, which is scheduled for next Friday, May 22nd, will be focused on treating individuals with disabilities. And folks, and we'll also be talking about vaping in oral health. The last thing I'll say is another just housekeeping logistical issue is we will be sending out evaluations for everyone to fill out and submit back to us. And those are also going to allow folks who are looking for CEs to get their CEs for participating in these presentations. Let me see if I can share this screen here. So this is the website that all of you who are registered are probably familiar with, but these are the dates that we have scheduled for our next sessions. Sorry, this was what I was having trouble pulling up. Thank you so much. Unless there are any other outstanding questions or issues, I think we can wrap up.
Oh, I think Sherry said something about trouble logging in. So maybe someone can put in their information so that she can get to it next time easy.
Oh, and there's one last question about the MPH program. If it's full-time, I'm not sure if you already addressed it.
Yes, it is full-time.
Oh.
Yeah. Well, I mean, you can do it while you're working. It's 2 courses per term. But I did put in my correct email address there, so please do reach out or click on the link. But would love to chat with any of you if you would like to. Have a great rest of the day.
Thank you. Thank you to our presenters. Thank you to our participants. And thank you to all our partners, especially AdCare, who coordinated all the logistics and to our closed captioning.
Yes,
for
thank
helping
you.
with accessibility.
Yes, Stephanie, we were great. Thank you so much, everyone.
All right. Thank you, everyone.